Welcome to the Friends of NPACE podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Hi, and welcome everyone to the Friends of NPACE podcast. I'm Terry Schmidt, family nurse practitioner, and you guys know the executive director. So honored to be here at NPACE doing these podcasts today. I am so excited to podcast again with a human who I just greatly admire. I've heard her speak. She's getting ready to speak for us in Napa. There will be more information on the same topic. And then she's also going to talk about postpartum depression. But of all the speakers I've ever heard talk about how to talk to your patients and practical advice, she is number one in my list. So Dr. Debbie Granick, thank you for being here with us.
Thank you for having me.
Yeah, so you are a licensed clinical social worker, which really gives light into your foundation and all of this, but you're also a doctorally prepared psychiatric nurse practitioner. The audience knows sometimes I struggle with words. I'm going to blame it on menopause. And you have a master's in public health. You worked over 30 years in the mental health space. And you divide professional time between clinical practice, like all of us do, and providing medication management and therapy. But you are also a thought leader and a published author. Do you have a new book coming out before we get started in the CE portion of this show? Do you?
I do have a new book coming out. It's called The 20-Minute Therapist, and it's being published by Carlot Psychiatry. And it's called The 20-Minute Therapist because it speaks to the brief visits that most of us have when we are prescribing clinicians, nurse practitioners, and need to be therapeutic, but need to do it quickly, don't have these 50-minute visits. So it's focused on how can I provide, clinical mental health information in a brief format.
I love that. We're going to have to check that book out. Thank you for sharing that. You're here today to talk about a topic that's not only mandatory for most of us as clinicians to have some CE time in. So audience, we are actually going to give continuing education credit for this. And at the end of the podcast, I'll tell you where to find that. But all of us, if you've been anywhere in clinical practice for more than a week, you've had a patient experiencing intimate partner violence, whether they realized they were experiencing it or not. Why is this an important topic for us as clinicians?
Yeah, I think it's important because of two things, exactly what you just said. It's a lot of our patients, and they might not know it, but especially we might not know it, right? We might not know, we generally don't know who's suffering. I'll focus on women mostly because that's the focus of your upcoming conference. But the bottom line is at least half, if not more, of the women walking into your practice have experienced some kind of intimate partner violence. And most of them are not going to disclose it. So at least not the first time. And so it really is incumbent on us to find ways to care for these people and what they're going through without necessarily hearing it directly for them and not necessarily knowing exactly who it's happening to. So we could definitely get into all the different ways that it presents. And
I was actually going to ask you that as the next question. 50% in mental health care settings. Wow.
Yeah.
Okay.
Yeah.
So how does it show up in the exam room? What am I?
Right. Well, for those of your listeners who work in an emergency room, that's often where we think of domestic violence showing up. And often that's because we think of domestic violence as hugely physical. And it is often very physical. And that's actually in its most dangerous form. But it also shows up a lot in OBGYN offices because a lot of intimate partner violence is sexual coercion or sex with a partner who outside of the woman is, not using protection. So you see STIs. It might be, rape. It shows up in pediatric offices because these women love and care for their children, and it's there in the office, whether or not the pediatric nurse or nurse practitioner turns to mom and says, how are you feeling? How's your mental health affecting your parenting? It shows up in mental health offices, and it shows up just in primary care. You probably saw yet again, nurses were seen as the most trusted profession in the world, 24th year in a row. And so it shows up because people just seek us for all kinds of support, right? So, again, we expect to see maybe a black eye or a woman wearing a long shirt over, a bruise. But a lot of times it shows up as like these diffuse kind of physical complaints, recurrent stomach pain, recurrent like pelvic, genitourinary kind of stuff, stomach aches, headaches, I'm not feeling good. And it shows up as mental health complaints, stress, I'm not sleeping well,
Insomnia. Yep.
I'm depressed. I just feel super reactive and irritable. I'm crying a lot. Yeah.
So I'm going to get tangential already. The audience knows I do this. So in sports physicals, when I would do those, now I'm practicing mostly telehealth, so I'm not doing those anymore. There was a mandated question on that form about, do you feel safe at home with these adolescents? Are we asking that question in well exams or urgent care visits if someone just comes in for GI complaints?
Right. How are we screening for this? Well, your point about addressing this in sports physicals is right on, because actually the majority of people who suffer from interpersonal violence, domestic violence, experienced it before the age of 18 in like this teen dating violence. So it is a good question. Now, is the question, how do you feel safe at home? It's quite possible they feel quite safe at home, but they don't feel safe with their boyfriend or possibly with their girlfriend, right?
Yes.
So there is a lot of question about who should be screened and how often. What there's not question about is that it does not appear there's any harm done by screening. Okay, so we know we're not going to harm people by screening them. Do we know exactly how often to screen, how to screen, where to screen? Different groups say different things. There's also real clarity about certain kinds of screening that are not good, right? This like automatic partner notification for STIs, not good, right? In a situation where there might be domestic violence. But I think, and maybe we could go right into this, I think a lot of it is like how we're phrasing our question. And even more importantly, even maybe stepping back before that, how are we setting up our offices, our practice, so that when we ask the question, we stand the best chance of getting a response that allows us then to be helpful?
Yeah, I think that's actually a good place to start, to back up, because I took us way off course, but sometimes in primary care, I've found with patients, especially the ones where you just see them and something's not right. Like I know something's not right, but that I almost have to see them several times and establish a trust relationship before they're ever gonna.
Yeah. One of the early things that kind of walked into my office that helped me reevaluate how I screened was a woman who walked in with such diffuse mental health, and I'm a psychiatric nurse practitioner, all psychiatry. So such diffuse mental health complaints, I almost found myself getting frustrated. It was like, what are we talking about here? It was, I feel like I'm going to fall apart. I just feel like I want to cry. Are you depressed? No. Are you anxious? No. I just feel upset. And, she came back a few times. I think the reason she came back is, even though I wasn't sure exactly how to treat her, I just really focused on being supportive and validating how she was feeling. And finally, when she came back once, she told this story. She said, I had a rough weekend. I got into a fight with my husband about some money I had spent on our daughter. And I had taken the credit card and spent this money on our daughter. And that opened up a conversation about not what do you mean taking the credit card, although that's what my brain was thinking, but help me understand the finances and how that works in your home, and help me understand what was upsetting to your partner about this, which then started unearthing this kind of financial control. And I'm probably going way off topic here, but we know that there is a fairly predictable trajectory of domestic violence that can start a lot with this financial control and then move to more like verbal insults, some isolation, some threats, and then some physical violence. So it wasn't to that point, or that was never disclosed to me if it was, but we started having a conversation just about the financial control. And that was a huge step even for her,
Yeah, that would have stood out to me too. It's interesting that she had all those diffuse symptoms.
Yes.
You mentioned the physical symptoms before, like just chronic headaches and chronic pain complaints. And then
Yes.
I've seen patients, I had one who stood out to me in the past with chronic like migraines and headaches, and nothing would work. And she wanted something stronger and something stronger.
Yes.
And she was using other substances to help with that. And she had GI complaints and all the things. And then one day she came in with a handprint right around her arm. It was very visible. And the whole time it's just living with that chronic stress.
And I think it's hard for us as helpers. We want to elicit whether violence is happening and refer immediately to care. And I think it's really important for us to reframe our own role as a helper, that even if you weren't able to help that specific person leave her violent situation, the fact that you were a trusted resource for her, for just a place to complain and get support for those stomach aches and headaches, to even contemplate disclosing whether there's other stress at home, it is sometimes as much as we're going to get. And part of that is not necessarily wrong. Again, like, leaving a violent relationship is the time that women especially are most at risk of death. So we always think, oh my God, I really want to get this woman out of this situation. I saw this patient today. I can't believe what she's living with. We got to get her out of there. It's like, well, not so fast, right? Like that is obviously the end goal, but our primary goal is her safety, right?
Yes.
And so remembering that for not for everybody, safety is not always ensured by getting someone out of a situation. It is often better to just have a safe place to come and a trusted person to talk to first.
Right. And dealing with their health issues and documenting. And they're autonomous adults. Some of these patients, don't want out of situations. So, all right.
And
go ahead.
I think the quickest way to shut down a conversation, if your listeners want to know, how do I shut down a conversation and make it so no one feels comfortable talking to me? It is to take away that autonomy, right? Because the thing that is most quickly stripped away in situations of violence is that sense of autonomy, right? Here's a victim of lack of control, and then they come into our office, and then we're like, hey, you got to report this. I need to report this. Here's what you should do. You got to get out of there. And everything we say that is trying to be helpful is just taking away at what little sense of autonomy they have left. So
I appreciate you making that point. Okay, since I took us off track, I'm going to go right back to the beginning. You alluded to as much as half of your female mental health patients have intimate partner violence at some point in time. But what are the numbers there? What is it, men to women? What are some of the major statistics that we should be aware of?
Right. Well, broadly speaking, it's at least double women than men, right?
Okay.
It is more women than men, and it's incredibly more women than men who die from domestic violence, right? So
Mhm.
the risk is much higher for women, and it's even higher of women who die from firearms in domestic violence situations than men. So, which is really important for screening. I think too, we focus on, how do you feel emotionally safe at home? And it was really big in the 90s to ask, do you keep a gun at home? Does your spouse have a gun at home? But that is definitely a predictor of death for women for sure. Um, we also know statistically that the a big risk group is young people, 18 to 24, women of reproductive age for sure,
Okay.
women who are pregnant. If violence was going on before pregnancy, it often escalates during pregnancy, especially if the pregnancy wasn't wanted, or if there's, financial stress in the home.
Sure.
We know that domestic violence crosses every demographic line, but it is more prevalent, believe it or not. This was news to me, in the gay, lesbian, bisexual community, queer community. So when you have a patient that walks in, as a member of that community, just to use, have your eyes open for that more. It is more prevalent in a minority communities, and it's more prevalent in um, socially, economically disadvantaged communities. So
Okay. So all populations that deal with more stress, right?
all the
Day in.
populations that deal with more stress.
Okay.
Yes.
So stress is
Yes.
clearly a contributor.
Yes. And but also just in general, women who are victims or people who are victims of domestic violence use our healthcare system proportionally more than other people,
Oh,
right? Not only
okay.
probably do they actually have more physical
Right.
injuries, but they also just come in more for help. So even if we say, you know, 30% of women over their lifetime are victims of sexual violence, half of who you might see in your practice is a victim of sexual violence, right? Because they might come in more often.
Oh, more
So
frequently.
those numbers
Yeah.
are higher. I actually looked at these statistics and it was like, so if the CDC says more than 1 in 3 women has been abused, then it's the question of like, how does that look in your typical practice day of say 22 patients? That's a lot. 4, 5, 6 of the people you see every day, have experienced this. So,
Yes, have or will have or are
hmm
currently. Yeah. Ha
hmm
Do we have any statistics on how many people reach out approximately for to
most
let
don't.
someone know? Most, the
Most do
majority
not.
don't.
Most don't. Right.
Okay.
And why is that? Why, what are we doing wrong or what's not happening right? I think uh, there's a lot of shame.
Mhm.
Um, I'll share this story. I think I told you this, Terry, but even from our most well-meaning perspectives as nurses, we sometimes just get it wrong. And one of the ways I first saw this was a young woman who was giving birth to her third child. I think she was about 19, it appeared to be from a low socioeconomic status and a minority female giving birth. And the nurse, when she was in labor, said, I had a sister-in-law, I think, who had 3 babies really young, but then she went back to school, got her degree, and really got her life together, and she's doing well now. And I just like cringed on the sidelines because I knew that this nurse was so well intentioned. She was trying to instill hope and
Right.
belief, but instead she was saying your life is not together now and you need to change to be a more acceptable part of society, right? So um I think a lot of people suffering from domestic violence have gotten that message in different ways, so we have to be really careful how
Mhm.
we try and heal, how we try and help, right?
Right. The
Um,
words we use matter.
yes. But there's shame, but there's also a lot of fear. Again, we want to say, get the heck out of there, right? But they're afraid that their children will lose their health insurance. They're afraid of their own financial ruin. I worked with someone, Terry, who this woman had had an abortion. She had children, and then later she had an abortion, and was separated from a man who it turned out had been very abusive. And when she said she wanted to end the relationship, he said, I will tell the court that you had an abortion that I didn't know about, because I guess he didn't know at the time. And she lived in a very conservative community. And I will tell the whole community that you had an abortion. I will tell our church. I will tell our kids. I will tell our families. Right. So fear is big, right? And then you add that on to someone who's already feeling really powerless and degraded and low self-esteem, and ask them to just reach out and say what's going on and hope that help is provided is a big ask, I think.
Yeah, I agree. It's a lot. And to think about the number of women who aren't believed in intimate partner violence, or the amount of time that intimate partner violence was okay in the eyes
Yeah.
of the law, right?
Yeah. Yeah.
Forced sexual encounters were not
Yeah.
called what,
Right.
what they are in a marriage.
Right.
I don't know how much we will get censored by using terms like rape, but that
Right.
it just didn't happen, right?
Right.
In marriage.
It was just called marriage.
Right. Exactly. All right. As we think about that, and I start turning over the conversations, because I always do this with every patient. Should I have said this way or that, whether it's intimate partner violence or not?
Right.
I rehash
Right.
things in my head. I have
Right.
for all of
Well,
my
that's
decades.
you do that because you're a good provider, right? And you want to do the best you can. And so it makes sense to ruminate a little bit. But I want to spare you a little bit of stress in that age-old phrase, it doesn't matter exactly what we say, it matters how someone feels, does really appear to be the truth when we're working with victims of domestic violence. That all we have to say if someone were to disclose this is, thank you for sharing that with me. I'm sorry that is happening to you. That sounds really difficult. And you can, at that moment, close your mouth. Of course, your brain will be going, oh my God, what do I do next? What do we do? Right. But you don't have to respond to it with, oh my God, okay, here's the next 4 steps or 5 steps. In fact, doing that can actually more quickly cut off communication because the person gets freaked out. Right. But just, that sounds really hard. You're not alone. I know this walks into my practice a lot, multiple times a day. And I am here for you, and I want to support you in whatever support looks like to you. And I won't make you do anything. All of this can be at your speed, at your pace. It can be nothing. It can be everything. But thank you for sharing that with me. I bet that was hard.
I like that. Thank you for sharing and trusting me with that. I'm sorry you're going through it.
You don't deserve this. Share.
Right.
Yep.
Those are important phrases.
Yes. Even those 3 things. Thank you for sharing. I believe you. And I'm sorry you're going through this. And you don't deserve this. And I would probably add it, and you're not alone. Okay. We think that almost half of women experience this. And actually we think even more than that experience some kind of, sexual violence, but not even going to those statistics, but just saying those couple things is helping someone feel like they're in a safe, caring place. And that's huge.
Yeah. I think it would make anyone feel seen and heard. So I appreciate this conversation. I want to circle back to just acknowledging different forms of abuse other than maybe what we've talked about. So you started with financial, and of course we know that there's sexual violence. We know that there's physical violence and psychological, but those kind of get broken down, and we're missing the whole digital aspect. So can you just address some of that?
Well, and another one to address too, there's digital, and then another one I think that's important is kind of this health, this medical. So in terms of digital right now, it's all about stalking, right? Like people getting access to each other's phones, people stalking each other. I had someone whose partner had not implanted, but had put a tracking device on their car because she had taken off the whole Find My everything. And at some point, he just went to her parked car in the night and stuck it on the bottom of the car. So we have all these tools to do this with each other, putting things like that into kids' backpacks without another parent knowing. And all of that is, a form of violence when it's not wanted by the other person. Hacking into someone's social media, posting things about that person on social media, exposing that person's private information. I think that's going on a lot. And in terms of the health violence, that's important for us to understand is that in some violent households, you see forbidding someone to access care. You see forbidding access to medication. You see forced use of medication. Forbidding or forcing some kind of contraception. So that's really important to attend to also. I worked with someone, it's been quite a while, who was a victim of sexual violence. I was prescribing Ambien for this person because she was having trouble sleeping. Well, it turned out her husband was giving her more Ambien than she was prescribed without her knowing, and was abusing her sexually. So part of our harm reduction was, okay, this isn't a safe medicine for you to have in your house, right? So I can't get you out of this situation. You're not ready to leave, or it's not safe to leave, or that's not my place. But I can talk to you about strategizing. How can we make your healthcare work for you, right? What can we prescribe for sleep that can't be overused and cause you to basically lose consciousness, right?
Yeah.
And I think, and this could maybe transition to how we set up our practices, but in terms of the using health as a weapon, we can protect our practices a little bit against that. So, a lot of this is based on the tenets of trauma-informed care. And I think as mental health practitioners, we're so trained in that. As a social worker, I was so trained in that. But I don't think we always do as well as with training our primary care nurse practitioners or pediatric nurse practitioners, sometimes miss some of that in training. But so here's a few ideas. So one is, obviously every practice should have a private confidential space. But then on top of that, I think it's really helpful to have it just be routinized that when you go get someone from the waiting room, you just say, I'll come get you later, to the partner, right? That it's not even a question. When we look at someone, and often it's obviously our medical assistant, when we look at someone in the waiting room and say, do you want them to come with you? Do you want to come alone? Do you want them to come back? Someone who's in a controlling relationship cannot say, no, I want to come alone. So having our office assistants just be like, I'm going to bring her back and I'll come get you if you would like to come, back later, or she'll be out in about 20 minutes. So there's no question, right? That can be very helpful. And then making sure, and it's so normal to lose sight of this, that we also, the whole time we're examining people, are saying, is it okay if we do this? Do you mind if I close the door? Are you comfortable changing into a gown here? Are you comfortable? We forget. We just walk in, we walk out, and we close the door, right? So always asking for consent, or is this okay, is also, really helpful. And then having it out in all of our offices in multiple places, just domestic violence resources. I love some of these resources that are now they'll have a Band-Aid box, and the Band-Aids have resources on them. They'll have tampon boxes, and inside the tampon, the tampon itself is a domestic violence number. In the bathroom stall, on the back of the stall, where probably someone could call confidentially, is a number. So those kinds of resources are available online. You can request those and put them in your offices, and just share. Even if you're not screening everybody, you can share with everyone, hey, we have these Band-Aids, when you peel them, they've got a domestic violence hotline. We have these tampons. take 10. We want you to share them with your friends, and just making those available to everybody.
I love that idea.
Mm-hmm.
Now I'm going to tell you a story. I worked rural health in an NPO clinic for many years. We were about an hour to an hour and a half from city. Some of it was very rural. And one of the things I saw in rural practice with women who were at home, like they would take the cell phone with them and take the keys to the car for the day. The male would, and they
Yeah.
would go. They would work the
Yeah.
fields. They would have the tractor. Like there is nowhere to go, even like especially in winter and other places. Just that isolation.
Yeah.
Where it doesn't matter. No one's gonna come. You can't call anyone. All
Right.
of the things.
Right.
So very much a control issue. We talked about underreporting a little bit, fear and shame. I want to get into why this is a chronic issue, and then I
Mhm.
want to ask you a tangential question about how we document or code
Yeah.
this so that whoever's getting the bills for the visit doesn't see
Right.
things, but how like this
Right.
comes up in charting. So
Right. Right.
you
So,
mentioned
yeah.
intimate partner violence as chronic health condition. Let's talk a little bit about that.
Right. Well, I think it's a chronic health condition because, and it's not just me that thinks that, because it comes out as health issues, right? That is the end result of domestic violence is either physical injury or psychological injury or sexual injury to the woman, to the man, to the kids. And where do health issues present? In primary care, in healthcare settings, right? So we are definitely on the front lines of being able to respond to this for sure. How do we respond to it in a way that is safe? It doesn't further jeopardize the person. So I think if you write the symptom, right? Like if you write the symptom you're treating, for example, in my field, I would write adjustment disorder with anxiety. It's so benign, right? Not only is it benign if an abusive person sees it, it's also benign if a court, a judge, a police officer sees it, right? If I know that someone has, or I suspect bipolar disorder, schizophrenia, a personality disorder, and I have a sense that this person might be in a violent relationship or whatever, I don't want to further risk the health of their family by putting a diagnosis on someone, I'm not sure that's what it is. Why not put the one that's more benign, right? And then there too, that's how we kind of bulletproof our practices, I think, with trauma-informed care is asking, is it safe for you to get a bill at this address? Is this okay? I say to my patients, I'm thinking that I'm going to use this diagnosis today. Is that okay? Right? They're very aware, right? So we know we have to be ethical. We can't lie, about a diagnosis, but we often have options and some are more inflammatory than others, for sure. Another just piece of documentation is that in cases where a woman does disclose domestic violence, if those medical records are used to verify that, it is really important that we just note objectively the injuries or the situation of the complaints.
Okay.
Just really clearly, don't need a whole narrative of, our own thoughts about it or anything like that, but just really making sure that we do document what we see so that if a woman does go through the stress of disclosure, that the fact that she came in and had those bruises that you described on her arm, that you didn't just neglect to write them down because the main thing was that she had strep throat. Sure, write down that she had strep throat, but also write bruises apparent on arm and stomach. When you do an x-ray and you're diagnosing an ankle, a broken ankle, write that it was a broken ankle, but also write evidence of prior fractures currently healed.
Gotcha.
So
all the documentation. Yeah. What you see. I appreciate that.
Yeah.
Okay, so we talked about how to document. We talked about bulletproofing our practices. Talk to me a little bit about our staff that work with us, the front office
Mhm.
staff, or our nurse who's rooming patients, like how do we prepare them for this kind of discussion?
Yeah. Um, well, I think letting them know these numbers, right? That, hey, a huge portion of who's walking in this door today is living in a really stressful environment, right? And some practices try and do a little bit of a morning huddle or something to kind of regroup. Um, it's not hard to develop this animosity in our practices, like, oh my God, that patient was so annoying, or this, that, the other, reminding ourselves that we are seeing our patients often on their worst days, right? And
Yes.
to try and look through that lens of compassion, and they're not
Mm.
trying to be difficult. They took 3 buses, 2 trains, and unpaid time off work and have 2 kids under their arm because they want help, right? Unless it's a court mandated visit, they're voluntarily coming to see you. So they're not trying to be disruptive, at one point we had to work with our office staff about if people were 10 minutes late, they would say, you can't see your provider. And we kind of had to go back and say, the nature of the patients we're seeing, in our case, people who are depressed or anxious or have ADHD or PTSD or are low income, by very nature, they're going to be late more often or miss more often. And we have to balance our own, financial reality, but the degree to which that we can try and be compassionate and say, I'm sorry that circumstances made so you were late today. I'm sure you had a really rough afternoon. Let me see what I can do. And even just saying, we really want to help you. I want you to be able to see your care provider today. Please give me a few minutes to see what I can work out. You know,
I think
um,
that goes a long way
it
with
goes a
patients.
long way.
I used to
Yeah.
have a mother and child in type 1 diabetes clinic who literally took 3 buses to get to his diabetes
Mm-hmm.
visits. And you know how frequently those are.
Mm-hmm.
And that,
Mm-hmm.
we did have to come to an understanding that if the bus
Mm-hmm.
system's down or one thing, they're not going to get here on time and they're
Right.
already in transit.
Right.
We'll work them in whenever they get here.
Right.
Right.
And I've also had the opposite happen where I had one woman who, when her partner knew she was going to the doctor, was a time that he would kind of stalk her. So she would come hours before her visit. And it was so disruptive. But finally, I was like, you know what? There's a reason she's doing this. She's done this 2, 3 times now. We're going to
Mm.
go with it. Right.
Hmm.
And so instead, we regrouped. We set up a waiting room that had snacks and drinks and books for kids and relaxing magazines, not just like Gun Life or whatever, and some nice lighting and some nice smell. And we said, we're going to be transparent with our patients. We're going to say, here, I'm really sorry. The combination of different people's schedules today has made it so our clinician is about 45 minutes behind. So we think we can get you to you at this time versus, like kind of what airlines do. Like, I don't know, you're just delayed, you're delayed, right? Um,
I
so,
like
and
that.
it
Inviting
changed
waiting rooms.
yes, it changed everything, right? And less stressed out patients in the waiting room make for less stressed out staff because people don't come in all perturbed. So the value of snacks and a tea coffee machine and some books and relaxing, nice reading material, lighting, and a couple little scented shigamabooms was great.
I love
Great.
that.
You know, some
Oh, yeah.
music,
Yeah.
music,
Some relaxing music. Yeah, I might hang out there
yes.
for a while. I love that.
Yes,
I
yes.
love that. Um,
Um,
so let's talk a little bit because I know we're going to run out of time and then audience, we're going to do a teaser here because Debbie's going to have more to talk to us about in Napa. But so I'm a clinician. I got 20 minutes with
yeah,
a patient. What does a trauma informed 20-minute visit look like? While in the back of my mind, I'm thinking this person could be at risk for intimate partner violence just because they fit into XYZ or because they're here.
right, right. So a 20-minute visit looks like you've set up your office, right? The person's coming back and you've done your best to kind of be operating from this place of autonomy, collaboration. Do you mind coming in here? Is this okay for you? Right? You're asking permission. You're
Okay.
allowing privacy and you're ensuring safety, right? You have your
Mhm.
materials out, just available. And one of the materials also to have out is just to say, you can use this space after our visit to make some phone calls if you need to. I
Oh,
also just do that. Like, when you're running between rooms, just say, this room is yours for the next 5 or 10 minutes, and then we have to then someone will come in to turn it over. That can be just great, right?
wow. Yes.
So making sure that, allowing kind of that to happen. Another is the concept of students. We all want to be great preceptors, but making it really okay to say no to having a student.
Mm.
Sometimes we're
Mhm.
walking out the door and we say, "Oh, I have a student with me today. Is that fine?" Really puts the pressure on the person to be like, right? But to say, I have a student with me. Some people are comfortable with that. Some people are not.
Sure.
The student has plenty of learning opportunities, but if it's okay with you that they're with me today, I'd be happy to have them. If that's not okay, I totally understand. And another day or never is totally fine. Like really saying that.
Okay.
Um,
Make no
I
comfortable. I got it. Make
yes,
him feel okay to say no.
make a no comfortable.
Okay.
When I actually was pregnant with my first child, my very first OBGYN visit was it like where they do the little vaginal ultrasound in this little dark room. And I was a new mom and my husband was in there. The doctor was in there. A nurse was in there. I think maybe someone dealing with an ultrasound, a student in this little teeny cramped room. I thought I was going to have a panic attack. And I never went back to that OBGYN. And they called me. They actually called and said, like, why didn't you come back? And I said, I was so anxious as a new pregnant person getting this first vaginal ultrasound to see if there was a heartbeat. And maybe someone asked if I could have, if a student was okay, but I don't remember really that option. And next thing I knew, it was all just happening, right? So remembering that victims of domestic violence are stressed and they need a little slower pace and time and clarity to answer our questions, right? So it's not just, is a student fine? Because that person needs an extra minute, right? So anyway, um,
I
so
appreciate that. Thank you.
yeah. So I think, those are big ones. And then just asking, you don't want to re-traumatize your patient. So if you know that this person's in a difficult situation and you know that they're having a mammogram in 2 months, you could say, like, we could do a breast exam today, but we also could skip it. You're having a mammogram. It's up to you. So, perhaps adjusting your exam based on,
Mm.
not re-traumatizing someone who's been in a bad situation, right?
Okay. Yes. I appreciate
Um,
that.
and then also just some physical ways we arrange ourselves, remembering that there's a real power imbalance when we're standing and the person's like sitting on this awkward exam table. So having your conversation when you're sitting and they're sitting. And the other is having a lot of your conversation when they have their clothes on. Like, sure, when they're in the gown, you're going to go through, oh, your skin looks good, your throat looks like it's infected, whatever. But when you're sitting saying, tell me how your relationship is affecting your health, how are things going with your children? How would you describe your stress level? Let the person have on their clothes, right? Before you are having those kinds of conversations. Um, I could talk about this forever, but I guess the last thing I would say is ways that we phrase questions so that people are more likely to answer them, um, would be, not just do you feel safe at home, but a lot of women experience, or a lot of people, so again, I'm focusing on women, but a lot of people experience violence at home. Sometimes that's physical, but sometimes that's financial or emotional or sexual. Do any of those resonate with you? Or are any of those issues that you'd like to talk about today? Not necessarily do anything about, but just talk about or share. So you're kind of putting it out there versus just the whole yes, no
I
thing.
like that. Yes, sometimes I have patients that have
Mm-hmm.
XYZ.
Mm-hmm.
Would you be concerned about any of that, or
Right.
does any of that resonate? I like that. So talk to
Right.
patients with their clothes on. Talk to them before
Right.
you touch them. Ask
Right.
them permission for all things to say no, but
Right.
particularly the student piece. And then
Right.
maybe give, sometimes patients deal with, because that's exactly why we ask, is
Mm-hmm.
sometimes patients deal with XYZ. Are you
Right.
experiencing that? Oh,
Right.
I love these.
Right. A challenging one too, especially in rural health settings, like what you talked about, is a translator who's not in their family, interpreter who's not in their family. But actually like taking time to try and make that happen if it's at all possible. Um, and again, making sure that we are really allowing privacy. There has been research that there is more disclosure that happens when screeners are done electronically, not just verbally.
Oh,
So if you kind of embed that in a questionnaire that someone can answer it just on a computer and you can see the answer instead of asking that you might get more information.
and then you can clarify, right? If someone says, I don't feel safe at home right now, you can say, hey, I saw you marked. Tell me a little bit about why that is. Is it
Yeah,
because the stairs are steep, or is it because, you
right.
think the electricity is going to be turned off, or is there something else that,
Right. Right. And again, I sometimes give this big range. And actually one of these ideas came from a pediatric nurse practitioner who I loved, and she said all these moms come in and they say I'm a terrible mom, and I've started asking them, did you burn your kid with a crack pipe today? And they say no, and I say, well, maybe you're not so terrible. Now, you have to adjust that appropriately, but the point is that if you ask a question like, I see you say you don't feel safe at home, does that mean, you're worried that your house is about to fall off the edge of the planet? Or does it mean that you live with someone who gets a little overly aggressive when they're drunk? And so by
oh, I
phrasing
like
it,
that, a range. It
you
gives
give
them the
them
ability to be somewhere. I
in the
like
middle
that.
or, yeah.
See,
Um,
what a good tip. You're so good at that.
and humor is sensitive, but it introduces a little bit of like, look, this is not the most stigmatizing, shameful thing in the world. We can just talk about it. Like, is this when you say things don't feel great at home, does that mean you're having sex 25 times a day when you want it to be once? Or does that mean it's 3 times a day when you want it to be once? So you give this range, which allows someone to say, I think it's kind of like 5 or 6 times a day when I want it to be once. It's not once, but it's not 25. Okay, now,
Gotcha.
so given
Yes.
that, you say that you get a little afraid of your partner when they've been drinking, or actually, I guess it'd be about you. You say that sometimes you drink to relieve stress. Are we talking, 3 cases of beer on a Tuesday, or three bottles of wine? And so most people are not going to say 3 cases of beer on a Tuesday, but so you've given them an easier entree, to be honest,
Right. Because it could be a bottle of wine. Okay.
Mm-hmm.
I
Mm-hmm.
appreciate the range. Okay, we're going to do that. I want to wrap up before we do this because you hinted at 4 things that we can say all the time when we get a positive screening,
Mm-hmm.
right? Thank you for
Mm-hmm.
trusting me. I'm really sorry
Mm-hmm.
this happened. You don't deserve this. I,
Mm-hmm.
I love all of those and not rushing to solve it. But what are a few things we shouldn't say or mistakes we make as clinicians when we get a positive screening?
Mm. The biggest mistake we make as clinicians when we get a positive screening, Terry, is not responding at all. So, really important to me when I started looking and studying domestic violence more was having a person very close to me, white, female, a very good economic means, and living in a very affluent part of town with very high functioning kids, who, over the course of a few years in her pediatric office, wrote that she did not feel safe at home and no one ever followed up. So I can't say any response is better than no response, because a response of dude, you got to get out of there. What's wrong with you is definitely very harmful. But operating within that, like, first do no harm, let me seek information. Let me just understand what you're going through and make it clear that I'm here for you to support your health, to help you find resources if you need to believe you, to validate you, to help you protect what matters to you, your children, you're going to school, whatever is important to you. So um, I think that's really the most important, is to respond. And then probably the biggest way to screw it up is to jump to trying to solve it for someone who's not looking for a solution and then feels that if they come back to you and they still haven't solved it, they're letting you down. Because then coming back becomes a source of shame.
Yeah.
Um,
I appreciate all of that. I think that's good for all of us to hear and be reflective on our own practices, because we do try to problem solve all the time.
Yeah.
Every visit, from obtaining someone's medications that are too expensive to peer reviews or managing their illness in ways and we're problem solvers.
Yes.
So just being present and acknowledging and not trying to solve that problem if that's not what the patient wants, I think is a good first step.
And remembering that even though this person is in this violent situation, this unsafe situation that might be very alarming for us, they are still a whole person with, like we said, with strep throat, with a rash, with anxiety. And we don't want the fact that they are living in a unsettling situation to be the focus of every visit. So we can say, what do you want to focus on today? What are your priorities today? What will make you feel that your time here was well spent? And letting them say, like, I really want to talk about anxiety, blah, blah, blah. And then, you can say, is there anything else you want to discuss? And you know what? If they say no, they say no. You've made yourself available. So it doesn't have to define that whole person.
I like that. And it's not the entirety of them, right? And they don't want it to define them. I appreciate that. All right, as we close up here, I do want to let the audience know that as a practicing clinician, if whatever state you're licensed in, you need to know the mandatory reporting laws for that state. They are not the same state to state. They are not the same for autonomous adult women who are not ready to report. They vary by type of injury, gunshot wounds, stab wounds, age of person. So know your own state. In this, when we wrap up, we're going to have some resources and links in the episode description, but we also have a compendium that we'll refer you to, not ours, but somebody else's who is much better than us, that put this together for state mandated reporting laws. All of you should know that and just have heard of that. Debbie, if every APP listening changed one thing or one thought about how they cared for patients experiencing intimate partner violence tomorrow, if they changed it, what do you hope that would be?
That the goal is not that someone leave. The goal is that, or that there is no outcome as that is the driving goal. That the goal is that this person feel that you saw them, listen to them, care about them, and are a resource for them. I think in many cases that is what we can do.
I appreciate that. That's very well said. Debbie, thank you for being here talking about this and for coming to Napa. You're going to be with us in November to talk about a little more in depth, and we're going to do some conversations, I bet, on intimate partner violence practice and postpartum depression.
Yes.
I love all of this. Where can the audience find you? Are you on social media? Do you have a website?
So I actually have an Instagram profile. It's the Dr. Debbie. So it's THE.DR.Debbie. And every Wednesday I drop a new nugget of information. It's called What to Say Wednesday. And it's about responding to common patient situations with just like a really brief, hopefully helpful clinical advice. So What to Say Wednesday. And then I have a website, debbiegranick.com, where I do have some courses and materials specifically about integrating therapy into your practice, probably more appropriate for nurse practitioners working in a psychiatric space.
I appreciate you sharing that. And I'm going to look for the nuggets because of all of the things in my decades in clinical practice, it's having conversations with patients. It's knowing what to say, I think, is the most difficult thing.
Yeah.
All right. We will post some CE for this. We are an accredited provider by ANCC, and Debbie's going to be with us in Napa. Be sure to check out npace.org for information on all things NPACE, and you can find out how to be with us for Napa. All of the people who are coming to Napa also get our pediatric virtual conference for free included in Napa. So that's a registration in September. So you want to get on that as soon as you can. Dr. Granick, thank you so much for being here. I can't wait to see you in Napa.
Thanks for having me. I can't wait either. It's going to be fun.
All right. Thanks for being with us. Bye, everyone.
Bye, everyone.